Thank you, Vijay, and thank you, Anand. Colonel, lovely to see you after a long time. And after two totally different types of lectures, the third lecture is going to be a little different. Okay. When this topic was given to me by Vijay, the first thing that I asked him was, what exactly you want me to speak? Then he told me there are a lot of issues. People are concentrating only on the medical management, even though it's not possible in primary care sometimes. I want you to put yourself in a position where you probably go to a village and you have nothing to treat. Okay. Happy to say that I'm a product of the Chennai medical education system. I was here, spent some time at CMC, spent 1.5 years at Chennai, learning under Professor Vishwanathan, and spent a lot of time with Dr. Moses, Anand's father, and then probably many of the seniors who are here. Well, we had only dianyl, we had only glyciphage, we had plain insulin, we had lenti-insulin. So it was kind of easy for me to actually prepare this lecture. Okay, let's just remember one thing. This is something that we have to remember today. It's multifactorial, influenced by genetics, lifestyle, environment, socio-economic factors. Each patient is going to be different, very difficult to generalize, and I was very happy, even though Krishna's talk was a little bit philosophical, each time you spend a little time, you try to pick up something new. Okay, let's also remember diabetes is not just blood sugar. Diabetes is going to be web of complications. And we know about these complications, so I think you need to be a Spider-Man to actually tackle, because you are doing a number of things. Comprehensive care is what we have been talking about. And this is the ICMR study which Dr. Mohan published, and we know the numbers. It's much higher than what the IDF Atlas of 2025 actually tells us. Yes, 101 million. The problem also is pre-diabetes, 137. A simple little statistics to many of you, most of you may know it. Every sixth person living in this world is an Indian, in the entire population of the world. Every sixth person is an Indian. And every 12th Indian living in India has diabetes. And this is the kind of a data that we are looking at. It's a huge burden. So when we talk of primary care, we must remember this is the kind of a burden that we are living in. And 67% of our people live in the rural areas. A very small number actually live in cities like Bangalore, Chennai, and things like that. So if you look at the data, if you look at the statistics, if you look at the burden, I think even the Spider-Man says, okay, I think I just would like to give up. Okay. So I think there's a huge task, right? Now, primary care and challenges, let's look at it from all the sides. Okay. Well, you can look at it from the infrastructure. Oh, I don't have the right infrastructure. There are issues with the doctors. There are issues with the patients. Oh, we love to complain about everything, except to accept we have failed to treat this patient. And I kind of like Krishna's talk, basically because we need to recognize, as doctors, we have to become humble. We have to become human. There must be a cause. Otherwise, I don't think the patient would have not done well. So there are issues. Nobody is saying there are no issues. You have to look at it probably from all the angles. So let's say we have a 3D look because it's a 3D conference. Well, these are the problems. Problems with doctors, problems with infrastructure, problems with numbers. And at some point of time, most of us, what's happening is we all have our own lives. You know, we will end up thinking, what am I doing here? Let me just make money. Or many of us feel, I wish I was an engineer, settled down in US and then not worried about all this. Okay. Now, Just quickly, let's go through. I mean, there are hundreds more reasons in the rural areas, right? We can talk about all these points. Oh, there is no education, I can't educate the patient, there are misconceptions. Yes, it exists. Non-adherence to treatment plans. Oh, they can't follow diet, they can't take medications. No, they have financial problems. No, my PSC is 50 kilometers away and they can't really come there because there are no bus stops. Yes, every one of them here. And I could have put another 20, 30, 40 more reasons. I'm sure all of you will add to this. Now, there are also problems with the doctors and the infrastructure. Let's accept this also. The shortage of trained professionals. CMEs are concentrating more on, okay, what was yesterday's lunch? Was it Andhra-based, Chennai-based, Bangalore-based? Inadequate CMEs, burnout, stress. In Bangalore, I don't know how it is today, endos are actually practicing in 3, 3, 4, 4 places. It's becoming tough because gone are the days when, you stick to your dobi, you stick to your barber and things like that. I mean, there are clinics everywhere, there are malls everywhere, people go to the nearest place. And the problem we also face with the doctors and infrastructure is team-based care is not there. Limited resources, data management extremely poor with the patients and doctors. Well, power cuts, shortage of medication. I mean, you can go on and go on and go on. Okay. Now let's come back to 2022-23 onwards. And if you are seeing a person with diabetes, if you are serious about treating him with whatever resources you have, remember, diabetes is turning out to be cardiometabolic, renal, vascular in approach. And these are the 3 eras, and we are in the 3rd era. We are in the 3rd era. You cannot differentiate, most importantly, a rich person with diabetes and a very poor person with diabetes. We are in the 3rd era. Now, this is exactly what the IDF told me. 2025 IDF meeting at Bangkok had a lot of issues. People were saying the talks were not good, this was not good, that was not good, people not there, etc., etc. But one of the important things that really came out of this IDF recommendations and guidelines is look at a poor person, look at a rich person equally, because both of them have diabetes. Okay, do not differentiate in the treatment. Okay, you can still control diabetes with the very, very inexpensive medication as long as you do this. And if you look at this one, just read only the right side of it. What they have said is, basic care is the birthright. So basic care itself has to be evidence-based. I mean, there were a lot of arguments. There were a lot of discussions. No, I cannot give the optimal care. What is basic care? It looks as if the basic care, optimal care is turning out to be the same. So much so, I completely agree with many of the people who discussed. They also said, okay, you can base it with your respective country, your respective region, take individual decisions at that. The only thing that also kind of shocked us was try to do HbA1c where we know we can't even do blood sugars. But then again they said, look, there is nothing that tells us how the diabetes is going. So do not differentiate between optimal care and basic care, but try to see how you can do the basic care in your primary care setup. We don't have to follow these recommendations. I can tell you that also. You may not have ways to do a HbA1c, you may not have the best method. But what really surprised me was, including even a CGM, which we don't do. But we were told it's absolute practice now in UK and many of the European countries and also Australia, where the treatment is free. Okay, in certain things we differ, but can we give the best of primary care? Well, huge number of people not diagnosed. Okay. Now, if you think that you can actually have a good PHC, it's not going to happen. It's impossible to have a good PHC roadmap in India because health is a state matter. You cannot bring the central government and the state government together. It's very, very difficult. I mean, and there are a number of improvement roadmaps. Now, can we have diabetes clinics? Can we have Namma clinic? Can we have this? Can we have every 100 kilometers a diabetes clinic? I think it's going to be very, very difficult. Every 100 kilometers, India is changing. Language change, behavior change, religions change, everything change. And look at the population, 1.464 billion, and 69% of them live in rural India. Also, don't forget, they will not see a doctor, they will not take the medication, but they have the best TV at home, they have a lovely mobile phone at home, because that's entertainment, without which they can't live. Taking medicine is not the priority for the rural India. Seeing a doctor is not the priority. Their mobile phone and a TV and a good two-wheeler and then cars. So how the mind behaves is something that we have to understand in the rural thing. I was actually running a clinic for the slum people in Bangalore for 10 years. And suddenly we realized that people have stopped coming. That's because between 10 and 1 in the morning of a Sunday, we would go only on a Sunday, we would go with a team of doctors, everything was being done. Genuinely poor people. The TV started showing 2 or 3 movies continuously in Kannada, Tamil, English, Hindi and other things. So these people said, can you people come and see us in the evenings? Because we don't want to miss the movie, I can't go to a theatre. That's when I realized we also have to look at the priorities of the people, and that's how the mind works. And I'm sure Dr. Sanjay Reddy will be talking about the mind, the body, the diabetes. So I think all sides of it we are going to realize that India is a great country, right? There's nothing wrong about the country. It's just that each one of us are different. So when it comes to treating, it's going to be difficult. This is what I was talking about. You will have all the slums, but you will have the mobile phones, Mera Bharat Mahan, and we are going to say it. Now let's come back to the question. What do I do as a doctor? I'm not put anyone else in the position. I was just thinking, okay, what will I do? Small town, village setting. Well, I'm not that dark, but that was a beautiful AI-driven photograph that I got. But then it sends you the message. I have only a glucometer and a BP meter. That's it. What I'm going to do is check fasting, postprandial, both if possible. If it's not possible, I'm not bothered. I'm just going to check a random blood sugar because I don't know at what time the patient is going to come. I'm going to sit, educate, ask him to come before food, something, whatever it is. Most importantly, I will also check the BP. A good clinical examination for foot to diagnose neuropathy and PVD. You just don't need any fancy equipment. My biothesiometers, my everything from 1991 is collecting dust. All the PGs are told, just use your hands, you can pick up. Maximum you need is probably a hand Doppler in small cases. Everybody agrees? Neuropathy is basically through ruling out the other causes. I know somebody will say alcohol, B12 deficiency, spinal problems, thyroid. But then at least with a good clinical examination, neuropathy and PVD can be diagnosed. Okay. Most importantly in the rural area, probably primary care, I think I would talk about foot care. The genital hygiene is, the more I see patients today who are not circumcised, especially on the male side, the more problems we are seeing. Ridiculously high amount of people have balanitis and phimosis and they have no idea what we are talking about. If we are serious about the cardiometabolic shift, if we are going to be using a lot of SGLT2, I think it's worthwhile spending a little time on trying to teach patients what is genital hygiene. So foot care, genital hygiene, two important things in all our patients, men and women. Basics of the diet. I'm not going to give a questionnaire that Krishna showed you all, your likes, your dislikes, how much of carbs you take, what do you take, etc. I'm not even going to ask them. I will just tell them, please reduce your portion size. If you are having 3 idlis, try to make it 2. Anyway, whatever you're going to tell him, he is not going to follow it. Okay? Only you're happy at the end of the day that you have put in an effort. So the best thing is, please, reduce it. Reduce the quantity, and you know this is what your sugar is. I think the portion size reduction is one simple way of telling our people you are eating a little more. Now coming to the medication. Okay, I would definitely look for a fixed dose combination if available, only for one reason. If you increase the number of tablets, most of these people, they don't like it. They think that diabetes has become serious, something is wrong, or it will damage the kidney. I would probably look for an FDCF and SGLT2 DPP4 metformin. If it's not available, it's okay. We can always give them separately. All right? And trust me, a small dose of ARB is not going to reduce the blood pressure drastically in any of the patients. I would close my eye and then put them on a small dose of 20 milligrams or maybe telmisartan and statins. I would not even worry about checking their lipids because 96%, we have done Cindy, we have done many trials, 96% of people with diabetes in India required statins. Statins have taken over. Close your eyes, start statins. Don't even have to bother. That's the only drug which reduces cardiovascular risk. Well, I put the word CCB only if the blood pressure is high. And if you look for a combination, you are getting combination. Why? People suddenly ask the question, oh, this is not rational, this is irrational, why India is coming out with so many FDCs? I fully agree with all the things. Okay, if I'm talking in another conference, defending, not defending FDCs, I would probably have points. But then, in a country like India, if you're treating in primary care, if you're seeing it's better. I have seen this happening. A patient doing extremely well on an FDC combination gets the card from ESI and says, sir, can I go get the drugs in ESI? Yes, he goes. 3 drugs, unfortunately, become 3 different drugs. 1 pill becomes 6 pills, and the patient is very confused because ESI has only those supply. Even though they tell him this fellow is my watchman, he doesn't understand it. So he stops taking the medications. So this is what I would probably do. We'll look at FDDs to reduce the pill burden and the cost, and after starting drugs which will not probably cause hypoglycemia or weight gain, if the sugars are still high, probably I will look for sulfonylureas, maybe basal insulin if the sugars are high, and spend time discussing all about hypo, self-injection technique. Try my best to tell them, okay, keep it in a cool place, insulin is okay for about 3 weeks. Well, if the infrastructure allows, what else do I need? I think the first thing I would pick is, if you want to evaluate for complications, there is one thing. If you don't know how to do a fundoscopic examination yourself, I would probably use for a fundus on phone to diagnose diabetic retinopathy, AMD and glaucoma, AI based. Still costs only 2.5 lakhs, no electricity, no Wi-Fi, nothing. Outbeats 90% of the best of the ophthalmologists. Tested at Shankar Nethralaya, Aravind Nethralaya, Narayana Nethralaya, everywhere. And now, except FDA approval, this has already got an approval. Then, gastritis versus chest pain related to MI can always be a problem. If I am in a small place, I would then put in an ECG machine. At least it will tell us by taking an ECG whether it's an acidity, or probably if I see some changes, I can probably refer them. Now, 2 areas where people are usually scared coming from PLOS basis is death and blindness. I went for these 2 only for that. Now, because when you refer a case and say you're going to go blind, please go see an ophthalmologist, they will run. Now, when you take an ECG and then if there is a problem and if you say, look, you got a heart attack, you will die, then they will go. These are the only two cases where people are scared. And when you refer, they will go. Otherwise, casually you tell them that, okay, diabetes affects the eye, you please go and see. At that point of time, his eye has no problem, so he will not go. Right. Lot of times it has been discussing with our minister, Jitendra Singh, who is part of RSSDI, still a friend, and he also says, PHCs are not going to be the solution. Diabetic clinics across India is not going to happen unless some entrepreneur comes forward and then says a PPP model and starts giving ideas to the central government. PPP will work, 50% from the public and 50% from the private. Somebody has to come out with it. Somebody has to say, okay, what is it that I need? How do I share a little bit of profits? PPP for free service, no, this is not going to work in India. PPP with a small philanthropic outlook, maybe a little margin to take care of the doctors. Because we did try diabetes clinics in Karnataka in a few PHCs. We impressed upon the government to actually fix a salary of 1.5 lakhs to the doctor, gave a nurse and an educator, gave a house to that particular doctor to stay, to run a diabetes clinic as a pilot project. What happened was the doctor did not stay because electricity and water was always a problem in that small little quarters that the government has allotted. So we have all kinds of problems happening. So PPP models are easy to talk about. We can talk about it for years. But somebody has to come out and say, okay, this is what I'm going to put up and let's see what's going to happen. So thank you so very much. It's been 35 long years working in diabetes and everything that all the previous speakers said is right. There are a lot of problems and then solutions are a little, but I think we should just move on. Treat every patient to our best ability. Okay. Never chase success, because success is for others to see in you, but most of us are trying to chase success and money. I think work to your conscience, work to your satisfaction. Everything else comes running behind you. Thank you so very much.